Welcome to the Alliance for Eye and Vision Research's annual International AMD Awareness Week Congressional Briefing, also held during Healthy Aging Month. I'm James Jerkowski, AVER's Executive Director. AVER serves as the privately funded Friends of the National Eye Institute within the National Institutes of Health. I wish to thank our co-sponsors for their support, including Research to Prevent Blindness, the American Macular Degeneration Foundation, and the Macular Degeneration Partnership. Co-sponsor ARVO, the Association for Research in Vision and Ophthalmology, has also assisted AVER with posting of this virtual event, and Novartis has provided support for event management. The NAI has a robust portfolio of research into retinal diseases, including AMD and diabetic retinopathy, including the diagnosis and treatment of these blinding eye diseases. So much big data has been collected on patients with AMD, including detailed images of the light-sensitive back of the eye called the retina, that AVER decided to focus this year's briefing on artificial intelligence in retinal diseases, including AMD and diabetic retinopathy. Our first speaker is Dr. Tiarnan Keenan, who serves as a staff clinician in retinal diseases in the Division of Epidemiology and Clinical Applications at the NEI. His current research is focused on the diagnosis, treatment, and prevention of AMD, including the application of artificial intelligence and big data approaches. Dr. Keenan?
Thank you very much indeed for that really kind introduction. I'm really delighted to be able to give this talk on artificial intelligence in retinal disease. I think it's a really important topic and a very timely one. And while I'll be focusing particularly on age-related macular degeneration, in fact, a lot of what I say will be very highly applicable to other common eye diseases such as diabetes, even glaucoma and other conditions. So what I thought I'd do was just spend a minute talking about what we mean by AMD and why it's an important problem. Then again to spend a minute talking about what we mean by AI, and then to move on to the main body to try and demonstrate what kind of opportunities AI may offer us in ophthalmology and why I think it's particularly well suited to that. So talking about some of the tasks I've listed here. And overall, therefore, to try and show how we're right at the beginning of an AI-based revolution in healthcare, I think, and how ophthalmology is right at the forefront of that. What do we mean by AMD? I think it's always really important to emphasize that this remains the leading cause of legal blindness in this country and actually in all other developed countries around the world. So whether it's data from this country or from the UK, as you can see, AMD accounts for as much as 50% or even a little bit more of all cases of legal blindness. So that corresponds to very large numbers indeed, and corresponds to a massive cost to individuals, to society, and even to doctors, as I'll be talking about a little bit later on. I won't say too much more about AMD mechanics and so on, but as you probably know, it's a disease that affects people particularly later on in life after the age of about 55 or so, but becoming very frequent indeed in the 70s and 80s. And so I just included a few images of what the condition can look like through its various stages and types. Luckily, in the kind of earlier forms of the disease shown here, vision is generally relatively normal. But sadly, it's over these kind of advanced stages where there's severe potential for decreased vision right to the point of legal blindness. And so as you probably know, there are two main forms of advanced AMD. There's the wet or so-called neovascular form, and then on the bottom is shown the corresponding dry or atrophic form. What I thought I'd do is just show a few images of the kind of eyes we see at different stages. And these are all color fundus photographs. So these are fundus photographs, simple pictures taken with simple technology of the back of the eyes. Indeed, they can often be taken on a smartphone these days and kind of beamed around the world. But these fundus photographs are the kind of thing where we've collected many, many thousands of them. And it's these kind of things where we feed them into our computers, we can design AI-based algorithms that can do really advanced tasks. But so as you can see for this individual, so this is the right eye and the left eye, the signs of early AMD are actually quite subtle. We look for these characteristic little drusen, these deposits, but it's very easy for an optometrist or an ophthalmologist to miss them. And that's the kind of area where AI-based tools, properly trained, can do a really good job actually at detection and classification for these kind of tasks, so we don't have kind of missed opportunities. In intermediate AMD, as you might be able to see, the drusen and the other signs are a little bit more obvious. And then we have the advanced stages, unfortunately, and in this eye here we've got an advanced scar from wet macular degeneration. So unfortunately this is a case of irreversible legal blindness in the central vision. And while this is a fundus photograph on one side of the image, I've shown the corresponding OCT scan on the other side of the image, and I'll be coming back to these later on. And then this is the other form, the so-called atrophic, the dry advanced form, where unfortunately we've got a kind of punched out looking area of degenerated retina, and the retina has essentially died in this area. So again, we don't have treatments for this. This is irreversible central blindness, and we try to catch these as soon as we can. So moving on to thinking about the scale of the problem, there was this nice study from Europe last year that pooled all previous population studies in Europe, and we wrote an accompanying editorial with this. So just to demonstrate the scale of the problem, it shows that actually over 25% of people aged 60 years and over have AMD of some stage or form. So over 25% obviously corresponds to very, very large figures. And again, because we tend to have aging populations in Europe and the States, this corresponds to big increases, so up to 22 million people thought to be affected by the time we get to 2050. So this problem is not going away. And looking at it from a different angle, from this perspective of the doctor, so these data from the UK were interesting. They showed that actually in 2017, for the first time, ophthalmology actually outstripped every other single specialty in terms of the number of hospital attendances. And so with a population of about 65 million, that was 8 million attendances in the hospital eye service in the UK, just in 1 year. And again, I think this is an area where AI-based tools can be really helpful. We have to think about new models of care, perhaps. There are some tasks that are very time-consuming for us that AI tools can actually perform quickly, with complete consistency, and very high levels of accuracy, probably even more than us specialists. So I'll show some examples of that later on. Just to leave AMD for a second and talk about what we mean by AI. There are many definitions, but I think we can think of it simply as getting computers to do human-like tasks, and particularly when we get them to learn from experience. So there are a couple of main reasons why there's been a big revolution in AI in very recent years, and that's one, the big growth in computing power, kind of demonstrated here, and secondly, it's the growth in big data, where we collect big data sets. And so the many thousands of fundus photographs that we've collected and graded and can feed into these computer algorithms is a good example of where big data sets work together with computing power. But it's particularly deep learning, a kind of subset of AI, that's driven the big revolution in AI in the past few years. And when we're talking about deep learning, really we mean computing power arranged in neural networks. So I've just got a very simple diagram here to kind of demonstrate that. I won't get into too much detail, but essentially with a neural network, we arrange the computing power in a particular way, and we kind of borrow some of the ideas and vocabulary from the human brain. But the basic unit is the neuron, and we connect these up in a kind of intricate web where the output of one becomes the input of the next, and so on. And it turns out that computing power arranged in that way is really good at learning by example. So for example, if you feed into a neural network like this many thousands of photos, and you tell the neural network to begin with, this one's of a cat, this has a dog, this is a car, without you telling how the task is to be done, the computer can actually learn by example, and it can start making those predictions without you telling it what's coming in. So there are so many areas of daily life where AI is involved these days, whether it's the idea of driverless cars or fraud detection algorithms. But in our smartphones, actually, we probably see it the most. So everything to do with automated voice recognition, facial recognition from our photos is all based on deep learning forms of AI. So what about medicine specifically? Well, as I've demonstrated here, I think any specialties that are very highly image-based, like dermatology, radiology, ophthalmology, lend themselves potentially really well to these approaches. So for example, in this paper, the authors trained a neural network to diagnose skin cancer, skin lesions, cancer, non-cancer, etc., just on the basis of simple photographs. And their performance was actually more accurate than human dermatology experts. And so the same idea with radiology, for example, diagnosing pneumonia on chest x-rays. But I just included this slide as a kind of caveat because there are challenges. So for example, it looked like this algorithm was detecting pneumonia really well from chest x-rays, but what these authors actually showed is that the algorithm was kind of cheating. It was actually paying attention to some of these little L markers that radiographers put on, and it was using that as a proxy to try and work out which hospital the scan came from, because there'd been a really big imbalance in the training data. So we have to be really careful about how we set up our training data sets. Ideally, when we test, we want to take the algorithm away from the data it was tested on, and ideally do a kind of pre-planned prospective test, and use these kind of attention mapping tools, as shown here, to try and peek inside the black box, to make sure that algorithms are always doing what we want them to be doing. So moving on to ophthalmology now, and as I alluded to earlier, I think ophthalmology lends itself really well to AI approaches for two reasons. Firstly, like radiology, it's highly image-based, so that works well. But also there's this idea that the eye kind of represents a bit of a window to the body, so we can learn a lot about what's going on elsewhere in the body by looking at the eye. I'll return to that in a second, but here's just a first very obvious example of how ophthalmology is right at the forefront of this AI-based revolution I was talking about. So this is Michael Abramoff and his IDX company. They designed and tested an AI-based algorithm to do detection and classification of diabetic eye disease, just from simple fundus photographs, like is seen here. And this actually led to the first FDA approval for any AI device in any field of medicine. So ophthalmology was right at the forefront there and remains so. Just returning to that idea of the eye acting as a kind of window to the body. So here we've got a video of an OCT scan. So I mentioned this in passing earlier, but essentially this is a three-dimensional image showing all the layers of the retina in cross-section that can be taken very easily, non-invasively, with fairly simple technology that we have available these days. And there are two kind of aspects to that. Firstly, we've got in the eye the only place where we've got direct visualization of the microvascular circulation, so all these blood vessels like we see. So maybe we can learn about blood pressure and other facts of the circulation from the eye. And secondly, with these OCT scans, the retina is actually part of the brain, so we've got a direct window on the brain in some sense. So there's a lot of interesting idea. Maybe we can use AI with these OCT scans, see if we can predict an individual's risk of dementia, for example, in coming years. And the first of those ideas is exactly what these authors did, just taking simple fundus photographs, but a very large number of them, and feeding them to a neural network. They showed that an AI algorithm can very accurately predict all kinds of features of an individual just from a simple fundus photograph, whether it's age or blood pressure, diabetes status, even sex, male or female, which surprised a lot of us. So we realized, I think, that there's a lot more information encoded in these photographs than we at present as retinal specialists are able to kind of extract. So I think that'll be a really big growth area in years to come. But just to return to AMD, I was going to present three fairly brief examples from my own research of where AI-based tools can be really helpful, all based on AI applications of fundus photographs. But the idea is to try and show three different examples of gradually increasing complexity. So the first one is a kind of detection yes-no task. The second one is more of a widespread classification task. And the third one is actually trying to look into the future with AI tools. So just to talk about the first one, the kind of simple diagnosis, detection, yes, no. So geographic atrophy, as I may have mentioned towards the beginning, is that advanced dry stage of AMD. And there's an example of it shown in the photograph. It's really useful to be able to get an AI algorithm to detect this accurately. So what we did is to use the fantastic resource of the NIH-funded AREDS, the Age-Related Eye Disease Study. And during the course of that study, we collected many, many thousands of images just like this one, every single one of which has been graded by reading center experts for a whole host of AMD features. But by feeding many thousands of these images into a neural network, and each time we tell the network, yes, this one has atrophy, no, this one doesn't, the algorithm can kind of train itself to perform that detection task. So we had a test set of several thousand images that we'd held back. The algorithm hadn't seen them before. And we asked it to make the prediction atrophy yes, no, and it turns out it can do this very highly accurately with an accuracy of about 97% or so. And shown on this kind of performance curve here, that's actually a little bit better than we can currently do as human retinal specialists on exactly the same test case. So that's a simple yes-no detection task. Moving on to a slightly more difficult task where we're asking it to try and do classification right across the severity of AMD. And in the clinic, normally as retinal specialists, we do a kind of 0 to 5 grading of severity. So what we did in this case was again using the many thousands of images from the AREDs. And we fed all of these into, actually this time, 3 different neural networks. So one was looking at drusen and 2 others at different aspects of AMD severity. And these are the results for each of those separate algorithms. Again, it was able to do this task very highly accurately, accuracy over 95%, which is actually superior to what we can do as human retinal specialists, shown by the little red dots on the images. And then when we pool these 3 features together, that's when we get the severity score between 0 and 5. And actually the AI algorithm could do this substantially more accurately than we can currently do. So that's a kind of detection, yes, no, a classification. But third is perhaps most interesting of all, seeing if we can use AI to help look into the future. And this comes under the context of personalized medicine, trying to take one individual's images of the back of the eye and say, how will that disease manifest itself in the coming 5 or even 10 years? And so the idea is we take fundus photographs from an individual in both eyes, and we're asking the algorithm to predict what is that individual's risk of developing late AMD at 2 years or 5 or 10 years, and will it be wet or dry? And there's all kinds of reasons why that can be very helpful for us. We have currently a couple of simple ways of trying to do that at present, but the retinal specialist has to be scrutinizing the photos very carefully, and they're applied to these 2 risk calculators I've listed at the top, but these are very crude really. They just give us often 5 levels of risk at just one fixed interval of 5 years. So to approach this problem, again, we were lucky enough to have the AREDs and the AREDS 2 studies. And so cumulatively, I think about 10,000 individuals through these 2 studies have been followed for 5 or even 10 years. And we've got really detailed information, so we know if one individual progressed to late AMD at 2 years, another at 5, another at 10, and was it wet and dry. We have all of that information, and we fed all of that into the algorithm, and it extracted the kind of predictive features from the images, and these were fed into a statistical model. But to cut a long story short, the results are shown here. So with our current methods of doing this, with a retinal specialist kind of scrutinizing the images very closely, we get predictions that are kind of 81, 82% accurate. But with our totally automated system, we got even more accurate predictions of 85 or 86%. And we can predict likelihood of wet versus dry, and at many different time intervals. But what I thought I'd do at this point to try and make it a bit more meaningful is to kind of demonstrate how an algorithm like this might actually work in real life. So here's a desktop application that we've developed from the AI tools, and it's not FDA approved. It's just a given demonstration of how we might incorporate this in our clinical practice, pending further validation. So you can upload a couple of photographs from an individual, and these are just standard fundus photographs. And the AI algorithm's at work, and just over the next few seconds, it does the detection and the severity classification side of things, as you can see on the left side of the screen. So it's correctly decided that there are large drusen. It's given a 4 out of 5 severity score. And then on the right side of the screen, we move on to the risk prediction side of things. And you can just key in a couple of key details like age, perhaps smoking status. And let's say we're interested in percentage risk of developing late AMD at 5 years. The risk calculation appears immediately, and we've got separate predictions for wet and for dry AMD. So here about 70% risk. But we aim to make the AI algorithms as kind of transparent as possible, so the physician can kind of inspect and see where the predictions came from, and can actually disagree. You might think actually these were medium-sized drusen, and you can disagree there and recalculate the risk and see how that affects the kind of risk profile. So I'll perhaps just show a couple of examples. I'll upload another couple here from an individual who's a little bit less far along in the kind of AMD course. And so again, it's doing this severity classification, and this time we've got a severity scale of 2 out of 5 instead of 4 out of 5. And particularly the right eye is a little bit less far along, so the risk calculations kind of come down as a result. And just one final example, I thought I'd include an individual with late AMD. So one of the photographs is a fairly easy case of wet macular degeneration, and the system picks that up. But the other one is advanced dry macular degeneration, actually quite a subtle case, but the algorithm picks it up. And so severity is 5 out of 5, and the risk prediction is no longer relevant because we already have AMD in its late stages. So that's how some of these algorithms might work in kind of real life, as it were. So what I thought I'd do at that point is return to the OCT scans that I was talking about earlier. This is fantastic technology where we get really detailed cross-sectional images through every layer of the retina in a non-invasive way. I haven't said so much so far about wet macular degeneration, but as retinal specialists, a lot of our time is taken up seeing patients with wet macular degeneration, having injections in the eyes at very frequent intervals. So every time we do an OCT scan, and we have to peer through every single one of these kind of 250 slices or so, trying to look very carefully for fluid and see if the fluid is more or less. And these are the kind of really time-consuming and difficult tasks that, again, lend themselves really well to AI. And so I've just included 3 different groups here, and there are probably more, but these are 3 well-known groups that have all developed algorithms that can do this very successfully. We just wrote a perspective paper that's under review, so I included a couple of examples from that. So here's one of the algorithms. I happened to choose the Vienna one, but it could have been one of the others. And it's an eye with wet macular degeneration, and it has some fluid. But what the algorithm has done quickly and automatically is to detect this fluid. It color codes it, so it distinguishes between fluid in the retina and underneath the retina, and it color codes them red and orange. And then the physician can actually inspect them and see if you agree or not. Not only does it do that, it actually does something that we're currently not able to do with existing technology. It quantifies them. So we've got 300 nanoliters, for example, of fluid under the retina. And that's very powerful because it can do that every successive visit. We can see with our treatment changes, is the fluid getting better? Is it getting worse? And we've got these great heat maps as well. We can see at a glance the extent of the fluid according to which tissue compartment we're interested in. So these are some of the areas where it can be firstly very time-saving, secondly potentially very accurate, and save up a physician's time for things that only a human can do well. And as I alluded to earlier, very often we have an algorithm developed, but it kind of languishes a bit there. It's really important to take the algorithms and take them far away from their training data, and in a kind of pre-planned or prospective way, test them on a totally different set of eyes with kind of pre-established parameters. And so that's exactly what we did in this paper. We took the Notile vision algorithm, one of the ones I mentioned previously, and we set it to work in a pre-planned way. So we took over 1,000 eyes of individuals that were coming for an AREDS 2 study visit. We actually got the retinal specialists to look at the OCT scans and see whether they thought fluid was present or absent. And actually, without telling them, we got the algorithm to do exactly the same task on the same OCT scans. And all the performance metrics are shown there, but essentially the algorithm outperformed the retinal specialists. So it's potentially highly accurate as well as time-saving, but the physician, I think, will always have oversight to see if the physician agrees or not. Here's a couple of examples I took from the paper of more OCT scans. So the one on the top is, again, wet macular degeneration, a very large amount of fluid that a physician's not going to miss. But in these cases, we have the quantification, so 3,000 nanoliters, which is really helpful for our treatment decisions. And then on the other end of the spectrum, on the bottom example, we've got a case of wet macular degeneration, but very subtle, tiny amount of fluid, that just the kind of case actually we can often miss, and we have to be scrutinizing scan by scan to try and pick up cases like this. But the algorithm picks up these very accurately, it quantifies them, and for example, this means we can catch wet macular degeneration at the earliest possible time point, because we know if we start treatment early, the visual outcomes are better. And I've got one final example, moving away just from fluid detection and tasks like that to a more ambitious, a kind of diagnosis task. And these data come courtesy of Keenan, who's a colleague in London, And this work was a result of a collaboration between Moorfields Eye Hospital in London and DeepMind, an AI company. And so to approach this diagnosis task, they split the problem into two. So on the left of the figure, you see the raw OCT image as it comes off the machine. Then they took one neural network to produce this kind of tissue segmentation map that's shown in color in the middle. But essentially, to try and approach this diagnosis and triage problem, they took the raw OCT data and kind of did a two-step approach. So in the first step, the neural network is going to take the raw OCT data and perform kind of so-called segmentation, where the network decides every single pixel from the scan is attributed to one or another tissue layer. And these could be kind of normal tissue layers, as shown in green here, or abnormal ones, as shown in the blue or the red that I'll come to later. And with that data, then a second neural network takes those data and considers a whole range of different eye conditions to do the kind of diagnostic assessment, whether it's wet macular degeneration, macular holes, all kinds of other conditions. So again, I thought it would be interesting to try and see it in real life. So this is the first neural network in action. And here we can see the black, the kind of gray and white pixelated image is the raw OCT scan. But slice by slice, the neural network has done the segmentation. So it's decided that all those pixels now shown in green are normal retina, but the ones shown in blue are actually fluid under the retina. And the red shown at the bottom is a kind of abnormal layer, a PED so-called, that's quite characteristic of wet AMD. And so it does this for every single slice to produce a kind of three-dimensional map, all segmented by tissue layer. So that's the segmentation side of things, and then the second neural network gets to work. And this is going to show in a second it all going simultaneously. So this is a case of an individual in his 70s with wet macular degeneration, but all the algorithm gets is the OCT scan. And this is the raw scan here. And then the first neural network does the segmentation, kind of slice by slice here, as the algorithm works through the 3D scans. And when I play this, we'll just see the algorithm going. It kind of goes slice by slice through the scan. And at the bottom, we see the first neural network doing the segmentation in that color-coded way. And kind of in the middle, we see the subretinal fluid, and the PED boxes are lighting up bright because it's detected those abnormal kind of tissue types. And then right up at the top, we see it's decided with 99.5% probability that this is wet AMD. All it gets is the OCT scan, no additional information. And that comes with a 99% likelihood of an urgent referral. This patient needs to see a retinal specialist straight away to start considering anti-VEGF injections for that case. I've got one more example of that might be interesting to look at, a different retinal condition now. So this is a man in his 50s with diabetes and reduced vision, but all the algorithm gets to know and gets to see is the OCT scan. So the raw OCT scan is shown at the bottom left, and the first neural network is doing the segmentation slice by slice, and from the color code, this one looks quite different. So the pale blue represents intraretinal fluid kind of leaking and accumulating within the retina. And so for that reason, in the central boxes, intraretinal fluid lights up very brightly, and the others much less so. And then the diagnostic assessment comes, so it's decided 99% likely to have macular edema, so leakage in the retina from a condition like diabetes. And that is a semi-urgent referral as opposed to the last case. So with these kind of examples, we can see how an AI-based tool may help us, not replace us, I think, but help us in terms of diagnosis and a kind of triage suggestion. And indeed, when they did this evaluation on 1,000 kind of new cases, the algorithm totally by itself, with access only to the OCT scans, got the referral suggestion right 95% of the times, which was actually higher than all of the other retinal specialists. And I believe it didn't miss a single urgent case. So just to conclude, I hope I've demonstrated how AMD is a really important problem. It's not going away, and it's certainly growing in terms of its burden on patients and on society. And even on doctors, we have to kind of think potentially of new models of practice. And I think some of the tasks here I've listed at the top are ones where AI lends itself really well. It can perform often more accurately than retinal specialists, with complete consistency and at speed. So I think kind of as suggested by the slight change in emphasis of these quotations from some AI experts, I don't think these systems will replace us, but they will definitely assist us to improve our performance and accuracy and potentially free up some of our time to allow us to do tasks that only humans can do well. I've not even had much time to talk about teleophthalmology, but that's the idea that, particularly times at present where it's not necessarily easy or safe to see a physician face to face, you can have an image taken of the back of the eye remotely, sent to a central location safely, and that can be assessed by a panel of specialists with AI-based tools. So I think we have to think about some of these new models of care. I also just wanted to thank all of my collaborators for the research that I presented from our own group. That's the result of an NIH-funded collaboration on campus between us at the National Eye Institute and my computer science colleagues at the National Library of Medicine. Thank you very much indeed for listening. It's been a real pleasure to speak to you about artificial intelligence and retinal disease and to tell you about all the very robust research we've been doing at the National Eye Institute. Thank you.
Thank you, Dr. Keenan. Our second speaker today is Dr. Alvin Liu. Dr. Liu serves as an assistant professor of ophthalmology in the Retina division at the Wilmer Eye Institute at Johns Hopkins University. He is a vitreoretinal surgeon whose research focuses on AI applications in automatic optical coherence tomography analysis. He is also involved in value-based medicine implementation, specifically as it relates to system-wide deployment of an AI-assisted automatic diabetic retinopathy screening program. Today's briefing begins AVR's 6th annual Emerging Vision Scientist Day on Capitol Hill, and Dr. Liu is one of the 22 early-stage investigators participating in this year's virtual program. Dr. Liu?
Thank you, Jim, for that very kind introduction. It's a pleasure to be here today. Again, my name is Dr. Alvin Liu. I'm a vitreoretinal specialist from the Wilmer Eye Institute, Johns Hopkins Medicine. Clinically, I take care of patients with medical and surgical issues of the retina, such as age-related macular degeneration, diabetic retinopathy, and retinal detachment. My research interest centers on the application of artificial intelligence, specifically deep learning, in ophthalmology, and it spans several domains, including development of fundamental deep learning tools, translational research applications, and actual implementation of AI technology in clinical care. Again, I would like to thank you for this opportunity to speak today, and I would like to give you my perspective on the key aspects that are necessary for successful implementation of AI technology in clinical care using diabetic retinopathy screening at primary points of care as an example. First, let me start with some background information on diabetic retinopathy. Diabetic retinopathy is characterized by damage to retinal vasculature, leading to vascular leakage, tractional retinal detachment, vitreous hemorrhage, and even blindness. It is the most common reason for vision loss in the working age population around the world, and its burden is expected to increase exponentially given the ongoing diabetic epidemic both in the United States and the developing world. Currently, each adult diabetic patient is recommended to undergo a dilated eye exam every year by an ophthalmologist. This is burdensome because this translates to at least 2 visits, one to the primary care doctor and one to the ophthalmologist. AI-assisted diabetic retinopathy screening at primary points of care is paradigm shifting, as it means that screening is instead done at the primary care office. Here's a sample scenario for that. A patient goes to his endocrinologist for his regular diabetes checkup. At the visit, color fundus photographs of his retina will be taken, and these photos will be automatically analyzed by an AI algorithm, which will then make 2 separate and different recommendations. Either minimal or no diabetic changes are seen, and screening should be repeated in 1 year, or enough diabetic changes are seen such that the patient should be further evaluated by an ophthalmologist. This technology is already FDA approved. In fact, it is the first autonomous AI diagnostic system approved by the FDA in any medical discipline. I would like to use this example to highlight the 4 critical factors that I think are necessary for successful implementation of AI technology in ophthalmology and in medicine in general. First, as the saying goes, well begun is half done. The critical first step of any deep learning algorithm development is the use of a patient-centric approach. What I mean is that the shiniest toy may not be the most practical, and an algorithm will only be meaningful if it can eventually positively impact patient care. For example, deep learning-based algorithms are now powerful enough to accurately predict a patient's sex, age, smoking status, and blood pressure from a retinal fundus photograph alone. While this feat is clearly superhuman and very interesting from a scientific point of view, it is unlikely to have significant impacts on patient care because these variables are already readily available and readily obtainable from the patients themselves. In contrast, a system that is described in my introduction, a system that can screen for diabetic retinopathy automatically at primary points of care without any human inputs, will indeed be impactful clinically and follow the philosophy of a patient-centric approach. This is because even in the United States, one of the most advanced countries in the world, only about 50% of adult diabetic patients undergo the annual recommended dilated eye exam. This is certainly problematic because we know that the lack of diabetic retinopathy screening on a regular basis can lead to delayed diagnosis. And delayed diagnosis and treatment can in turn lead to avoidable blindness and vision loss. Being able to screen for diabetic retinopathy at primary points of care improves patients' convenience, improves the adherence rate to annual diabetic retinopathy screening, and will likely lead to decrease in vision loss on a population level in the long run. This, of course, has immense public health and economic implications. The second critical factor is that once an AI application has been identified through a patient-centric approach, validated vigorously through sound scientific methods, and approved by the FDA for clinical use, then a favorable and up-to-date regulatory environment is needed for the widespread adoption of this technology. Luckily, in the instance of AI-assisted diabetic retinopathy screening, there were 3 recent favorable changes. First, the Centers for Medicare and Medicaid Services, CMS, recently announced that it accepted the addition of a new CPT code that will allow for the reimbursement of retinal imaging taken at points of care with automated interpretation. Second, the National Committee for Quality Assurance recently specified that an eye exam evaluated by artificial intelligence interpretation would indeed comply with the comprehensive diabetes care HEDIS measures. Third, the American Diabetes Association also updated their recommendations that an FDA-approved AI system capable of detecting more than mild diabetic retinopathy could be an alternative to current traditional screening techniques. Taken together, these 3 major changes in regulations, reimbursements, and professional society recommendations have made widespread adoption of this technology a lot more attractive and feasible. Now, onto the third critical factor. Within the context of a more permissive global environment, the actual implementation of an AI technology in clinical care requires extensive collaboration, communication, and planning between different players within the healthcare system. Using the implementation of automatic diabetic retinopathy screening at Johns Hopkins Medicine as an example, here are the planning challenges that we had to overcome. First, Johns Hopkins Medicine, like many other large healthcare organizations, has both regulated hospital facilities and unregulated outpatient spaces. The CMS regulations for regulated and unregulated spaces are different, and so are the billing requirements. Therefore, the medical legal team and billing departments at Johns Hopkins Medicine have been intimately involved to ensure that the billing practices of automatic diabetic retinopathy screening in both regulated versus unregulated spaces at Johns Hopkins are compliant with current CMS and insurance company requirements. Second, the IT department at Johns Hopkins University is heavily involved in the implementation of this AI technology because new functionalities are required to be built into our current electronic health record system, such as automatic identification of diabetic patients who should undergo AI-assisted screening and the incorporation of the screening results into the patient's charts. Third, there has been extensive communication between the primary care clinics and the Wilmer Eye Institute to coordinate patient care. For example, we wanted to set up a system that is as patient-friendly as possible. To that end, we set up a special Wilmer call center protocol so that each patient who screens positive for referable diabetic retinopathy will have a confirmed appointment in hand with the retinal specialist before he or she leaves the primary care office. The fourth critical factor involves flexibility and creativity to maximize the success of real-world implementation and a system in place for quality improvement. Again, using our experience as an example, we ran into unexpected issues during actual implementation. In the pivotal clinical trial that led to FDA approval of this technology, only about a fourth of the patients required dilation of the eyes for high-quality images to be taken. However, in our early experience, up to 50% of our patients required dilation. This was not expected and required us to change our clinic flow completely, which involved pre-identifying patients who likely required dilation and giving them dilation drops at the beginning of the clinic visits. For quality improvement, we also plan to follow these patients prospectively to ensure that patients who screen positive will be seen at the Wilmer Eye Institute in a timely manner, and also to ensure that the patients who undergo AI-assisted screening reflects the local patient populations so that the implementation of this AI technology does not inadvertently exacerbate racial inequality in access to healthcare. In summary, the invention and scientific validation of an AI algorithm is only the first step. There are many critical factors necessary to go from successful invention of a patient-centric deep learning algorithm to implementation in clinical care with a positive impact. These critical factors include an up-to-date regulatory framework that keeps up with the rapid pace of scientific discovery. And this requires constant, productive conversation between computer scientists, physicians, legislators, and regulatory agencies. Deep collaborations and detailed planning involving multiple players within the healthcare system are also needed. And last but not least, flexible adaptation during actual implementation and a system for constant evaluation and improvement are critical as well.
Dr. Liu, you've emphasized the engagement of a large number of teams in this artificial intelligence project. Could you comment briefly on the impact of the COVID-19 pandemic clinical shutdown on the project?
Jim, thank you for that question. It's certainly a very pertinent question, and unquestionably, COVID severely impacted our implementation of this AI technology. As I alluded to my presentation, many teams of people were involved in the planning and implementation of this program, and there were many moving parts. When COVID first happened, the entire focus and energy of Johns Hopkins Medicine pivoted to dealing with this pandemic, which includes making sure that it's a safe environment for the patient, staff, and faculty members. And also, one of the declarations from our governor was that we had to partially shut down clinical operations and only provide essential and critical healthcare services. And as a result, the rollout of this program was halted for several months. Also, ultimately, AI-assisted diabetic retinopathy screening requires the patient to be physically seen in the primary care offices. And obviously, during the peak of this pandemic, many patients were reluctant to come in at all. And so our enrollment went down as well. It's been a real honor for me to be here today, and thank you once again for the opportunity to present my perspective and my research work.
Thank you, Dr. Liu. Our third speaker, Jack Stewart, is a patient representative from the American Macular Degeneration Foundation. Jack was a Navy hospital corpsman from 1969 to 1972, working with Marines and South Vietnamese officers in training at the War College in Rhode Island. He retired from the Navy early due to vision loss from macular degeneration and worked for the remainder of his career as a respiratory care practitioner. Jack serves as the Secretary and Treasurer for the Blind Veterans Association of Vermont. Welcome, Jack.
Hello and greetings. As a corpsman in the Navy, I developed macular scarring when I was in, and I was discharged legally blind from the service. As we get older, there are many people in their 60s who develop the wet style of macular degeneration and start to lose their center vision. And in that, they have difficulty reading, watching TV, they have difficulty watching sports, maybe with their grandchild in the field. They have difficulty getting any place because they can't drive and they're dependent on other people to drive for them. I've had that most of my adult life now, not being able to just go out anywhere and have that freedom as a car gives us. I gave up driving when I was discharged from the service. That was very, very difficult and remains a difficult thing for myself and anybody else who's legally blind, especially if you're living in a rural area.
So you're wearing your own adaptive technology. Can you refer briefly to what you're wearing, what it does for you, and then lead into what you hope research can do for those with vision loss in the future?
Right now, I'm wearing basically my earphones, and then I have a magnifying glass, and it has several different magnifiers, and I can put two others on here. And it gives me a little wider field. Though my center vision is gone, at least it gives me a little clearer focus. With macular degeneration, there's a tendency, well, you don't have any focal point. A focal point is where you focus on. I mean, everybody has these smartphones and they're focusing on these little areas. I have a difficult time doing that, so I don't really have a smartphone. I have a computer that I use, which is big screen. I have lights on the side that I can use to brighten things up. For most cases, extra light is very, very helpful. There are other devices that I use. I use a Orcam, which is an AI device, which will actually read for me if the words are too small or if, basically I can't see them at all. And it also identifies, if I go to the store, it'll identify a product, it'll read the barcode for me, tell me what's in it, and it's extremely helpful. I know that a lot of the veterans are getting this kind of a device to help them. There are many other devices and the technology to help people and assist people with visual problems has basically tripled over the last few years. They're coming out with some really wonderful, wonderful things. Technologically, I think we've come a long way. Rather than just using lenses, there are other ways that we have to help people see better. It is such a visual world. And when you start to lose your vision, it can be extremely depressing. extremely depressing. But it doesn't have to be. I for a long time, had to look people straight in the eye. And since I can't see them when I look them straight in the eye, it was kind of funny. You look at me. I'm looking at you. You look at me. I mean, when you don't have any center vision, when you have macular degeneration, you have to look off to the side. So you can't be looking directly at somebody. But that kind of stigmatism that is in society, they just don't help. Oftentimes people who are starting to develop visual problems don't know what to do. They oftentimes will just sit at home and let it go, and just let it go and let their life go. And it's so very important that we get out the information, we get out the awareness that there are organizations, there are people who help. And there are schools of the blind all throughout the country that one can go to help adapt, improvise, and overcome their visual difficulty. Being blind, it's not the loss of everything. It's so very important. We help them adapt. We help them improvise with other devices, and to help to overcome their disability and not fall into it. And I would like to see some more support in Congress and elsewhere. Help those people in Congress for people with visual problems, especially those people who are unaware that there is help.
Thank you, Jack. And thanks to all of you for watching today's program. At 1:30 this afternoon, AVER premieres its half-hour conversation with its 22 emerging vision scientists entitled The Impact of COVID-19 Lab Closures on the Next Generation of Vision Scientists. We hope you'll join us.